Good morning. Thank you very much for joining us for this fourth webinar in our International Teaching for ENT Surgeons series. This webinar is entitled Vertigo. My name is Aurelian Geru. I'm the course director of Intents. If we haven't met before, just to give you an overview of the course, we have 6 topics delivered through 6 webinars. Part 1 of each webinar is dedicated to the UK patient journey of a patient with the title presentation. Part 2 is takes the form of a discussion forum on the lecture that has been presented. And then part 3, after the session, there's a reflective and evaluation form for you to complete. And on completion of that, your certificate of attendance will be delivered. So please write your questions in the Zoom chat, and it gives me great pleasure to introduce our 2 speakers today. Mr. Sanjeev Bimrao, who's a consultant ENT surgeon, and David Jay, who's a specialist audiologist in balance from the Manchester Royal Infirmary. Thank you very much for joining us, and please start your lectures.
So how do I share? I've got screen, yeah. Can you see my screen?
We can see your slides. Thanks, Sanjeev.
Hi, good morning from the UK. As mentioned, I'm one of the ENT surgeons from the UK. My name is Sanjeev Bimrao. So I'm going to cover the first bit of the discussion about history and examination of a patient with balance problems. Before we do that, we need to know that in clinics, we don't always get patients who present with true illusion of spinning. So they present with the different symptoms or description of the balance problems in different ways. So they may have a dizziness, they may come with lightheadedness, they may come with feeling unsteady on the feet, they feel like fainting. So it's our job to figure out what actually the patient is trying to convey. We want to know whether it's a life-threatening condition which the patient has got, which needs urgent intervention, or it's a benign condition. So to know that, we need to figure out how the balance system works. So as we evolved from being humans from apes, we have gained a vertical erect posture. So we always are perpendicular to the horizontal of the earth. So how does the body work? So we need to understand that. So most of the information for posture is by the eyes. The eyes give you 80% of the information, and they tell what's around you, whether you have to take a step forward or you're going to have to stand still, depending on what's surrounding you. And then you have the ears. The ears give us around 15–20% of the information to maintain your balance. They give you special orientation. They actually tell you whereabouts in space. If you close your eyes, you will know whereabouts in space, especially like in lifts. If you are in the lift, you can figure out whether the lift is going up and down or stationary. So that's given by the ears. Then you have additional information from your joints, the sensations from the feet, the neck. They give proprioception. So all of these are integrated in the reticular formation. You get inputs from cerebral cortex, you get brainstem inputs and cerebellum, and these are then fed through, analyzed, and the body then gives out signals, mainly to the eyes. The eyes help to keep the image on your macula. So you want the image to be as accurate as possible and as smooth as possible. And that is maintained by your vestibular ocular reflex. That's quite an important part of the balance system. That also has to maintain the posture. Posture is maintained by a coordination of muscles and joint movements to keep you in the position you are. And mainly driven by vestibular spinal reflexes. So essentially what you want to establish in your history and examination is you want to know where the problem is, where the pathology is, and what systems are affected, whether it is the ears which are involved, or it's the eyes which are involved, or it's the patient being anxious. So we want to figure out what systems are affected. So you want to elicit that in history. Then you want to come down to what might be the possible problem, what's the diagnosis. Then you want to figure out whether it's a stroke or a brainstem infarct, it's life-threatening or it's a benign condition. Then we have to decide how do we manage the patient. If it's something which you are involved with and you deal on a daily basis, you deal with the patient. Could be vestibular exercises, could be medications, could be surgery. Then if the patient has something which is unusual or outside your realm of expertise, then you want to see who's best placed to manage them. So you have to think of all these things when you are discussing or eliciting your history and examination of the patient. So coming specifically to the history, one of the first things you want to figure out in balance disorder, especially coming from the ENT side, is to figure out whether the patient has a true illusion of spinning, whether it's yourself or the surrounding, which is the true vertigo. And that is something which you want to tease out from the patient at the very beginning. Usually the first episode of the attack of their symptom will give you a good definition of what might be going on. Second is, as we just discussed, the visual information is the dominant of the two. When you fix your eyes, if the vertigo or your symptoms get better, then possibly likely to be a peripheral problem. So you want to figure that out in your history. Then any history of recent illnesses, certain infections can give you balance problems like vestibular neuritis. You want to ask for the history, want to check for any history of drug treatment, ototoxicity, any history of patients having underlying psychiatric problems. Then also systemic problems. You could have cardiac problems, orthostatic hypertension, arrhythmias. They all can give you balance problems. And neurological deficits, numbness, demyelinating disorders, all of these will give you balance problems. So you want to elicit that in a history. Now, coming specific to the duration of attacks, that's quite important. If you figure out how long are these vertigo attacks last, that'll give you a lot of information as to what might be going on. So there are a lot of conditions which give you vertigo which lasts for seconds to minutes. A BPPV, paroxysm vertigo, vestibular paroxysmia. This is a compression of the vestibular nerve within the intra-aortic canal. And they give you multiple attacks of vertigo lasting anywhere between 30 seconds to a minute, can have multiple times during the day. And they can actually give you seconds to minutes of vertigo. Then you have third window syndromes, especially the superior canal dehiscence. They can give you similar symptoms. Then you have symptoms which last from minutes to hours. Vestibular migraine can be anywhere between 5 minutes to up to 3 days. You can have Meniere's disease, typically for several hours, but most often it can be anywhere between 20 minutes to up to 12 hours. And then you have symptoms which can last for days, acute neuronitis due to a viral infection, or even a posterior fossa infarct, brainstem or cerebellar infarct can give you the same symptoms, and that can last for several days. Then you can have chronic vertigos, patients with chronic subjective vertigo, visual vertigo, or it's a triple PD nowadays called, can give you the same symptoms lasting for months. You can have bilateral vestibular failure. So the duration of attacks are quite relevant. So it gives a lot of information what might be going on with the patient. They want to know what are the accompanying symptoms, whether they're a fluctuating hearing loss, do they have tinnitus with it, they have oral pressure, they have blocked sensation in the ear. Meniere's disease can give you that. Then the patients can actually have bulbar symptoms such as slurred speech, difficulty in swallowing, ataxia, then hemiparesis. You can get that in vertebrovascular insufficiencies or central vertigos such as acute vestibular syndromes. Then you can have patients complaining of headaches. Patients can have photophobia, phonophobia, or abnormal sense of smell. That can be part of vestibular migraine. Then you want to know whether there is any illusion of eye movements in the head. that's oscillopsia. Sometimes oscillopsia is a presenting symptom. Patients can say they have symptoms all the time, especially when they're mobile, moving around, walking. Then you wonder the patient may have bilateral vestibular failure, or you can see vestibular oscillopsia in patients who have acute migraine attack during the acute Meniere's attacks. Then you want to know what are the precipitating and modulating factors, what actually make the symptoms worse. So BPPV, you can have postural positional problems. Patients may say, well, doctor, every time I turn in bed or look up or tie down, bend down to tie my laces, you can get dizzy. You can have central position vertigo like brainstorm. In fact, it does give you similar symptoms like a BPPV. Then you can have symptoms which can be evoked by changes in pressure and loudness, where there is a third window. This can give you similar symptoms. Then symptoms which are related when the patients are walking, like bilateral vestibulopathy, can give the same problems. So all the information is quite relevant to try and figure out what might be the underlying problems. So with the history, you will get a decent clue as to what's going on with the patient. As we previously discussed, we need to figure out what systems might be involved. So you have to have a systematic way of examining the patients. Starting from the ears, you want to look for any problems with the ear itself, any problems with the tympanic membrane, if there's any cholestoma, if there's any obvious infection which might be triggering the problem. Then you examine the vestibular system to look for any weaknesses, asymmetry. Then you examine the eyes for any obvious nystagmus. Then you check for the coordination, cerebral examination, joint proprioception, because things like peripheral neuropathy affecting a posterior column can cause problems with the balance. Then you check for the gait and posture. Patients have demyelinated conditions, can have extracerebral symptoms. And all of these assessments give you as to the likely part as to where the problem is. Coming back to the vestibular system, what exactly are we looking at? The vestibular system is governed by semicircular canals. We have three semicircular canals on each side, which are orthogonal parallel to each other and at 90 degrees to each other on either side. So they're responsible for angular movements of the head, and they drive the vestibulocular reflex. What do we do with the vestibulocular? The bedside test, which we can do, like head thrust maneuvers and head shake maneuvers, and it can be tested by caloric testing. Then you have the utricle and saccule, which is responsible for ocular tilt, head rolling, and these are done by vestibular spine reflexes, and they maintain posture and muscle tone. Sorry, my slide is stuck. Can you all see the screen?
We can see the screen, yeah.
What kind of screen should be seen? It's just
so the vestibular physiology is on the screen. Okay.
Yes.
So once you know where the problem is with the history, then you have to have a set of balance testing exercise regime, and different people have different way of setup. And we get 15, 20 minutes to examine each patient. So we set up a different way, but these are the tests. You can have a battery of tests from examination of eyes all the way down to cranial level examination. So the clinical tests of VOR is head thrust and head shake maneuver. I'll just show you the head thrust maneuvers. The Halmagyi maneuvers, they're quite good at assessing if there's any hyperfunction of the labyrinth in the peripheral labyrinthine problems, where the patient is sitting in front of you. You ask the patient to actually face you and look at the eyes, and they're looking at you, and you warn that you're going to be shaking the head and sudden movement, and look for any catch-up saccades. So this is the head thrust maneuver. Head shake maneuver is similar. You bend the head down 30 degrees and shake the head at 1 to 2 hertz per second, and then you see for any residual nystagmus. Then you have the vestibular spine reflexes, Romberg's or Plutiger Unterberger's testing. So this is a video from one of my colleagues, it's an audiologist. Then you have cerebral examination, which could be heel to shin testing. Then you can have rebound testing, alternating movement of the palms, turning back and forth on either side. And then you can have finger to nose testing. So that'll tell you the coordination. Then you have functional gait stability. I'll show you the videos in the next slide. Then you check for the gait. Gait generally are either an experimental gait or cerebral gait or taxi gait. That'll tell you there is a central problem. Then you can do the ocular testing by testing the extraocular muscle movements and the pupillary reflexes. So just to expand the vestibular, my colleague is going to cover that, but I'll just mention a couple of tests. Smooth pursuit generally is a central problem. The peripheral labyrinthine disorders don't affect the smooth pursuit. I'll just show you the smooth pursuit testing. You can we can then check for saccadic eye movements and dynamic visual acuity. I'm just going to show one last video. It's just you can have a combined eye movement. We can do all the assessments in one test. Then you can do the dynamic visual acuity basically using a Snellen's chart. The patient is standing 6 feet away, and they're looking at the Snellen's chart and trying to read the smallest letter possible. Then you hold the patient's head and rotate it 2 hertz per second and ask them to read the chart again. Any increase in the size of the words by 3 will show a positive dynamic review testing. You can use convergent testing, usually using a cell-opsia. Skew deviation is kind of the important test. It's used to make sure there is no brainstem or cerebellar problem, and it's done by cover testing or flicking the 2 eyes and see if there's any change in the eye levels between the 2. So the test, you have a battery of tests, but the history will guide you as to which ones you want to be testing to save time. And you can do the testing with optical and without optical fixation. Then you complete a testing by cranial examination, check for cerebellar testing. Then you can do gait and proprioception. So those are my set of tests I use. It can vary between the patients depending on the history. I haven't actually mentioned Dick Halpikes, but it's one of the battery of tests you can use in your daily examination. Then you have the actual vestibular assessment. If you still are unsure about the outcome of your assessment, the diagnosis, then you can go for the object tests, which is done by a vestibular audiologist. And there's a battery of tests, which I will leave it for David to cover. So that's in brief about history and examination. Are there any questions?
So we'll take questions at the end. David, do you want to
Okay.
start sharing your screen? Thanks, Sanjeev.
Okay, 1 second. Hello, everybody. Can we see the screen all right?
Yep.
Okay, great. So yes, we do. So part of my job is to do a lot of the laboratory testing, the video testing, goggle testing, things like that. But I'm not talking about that today because it's not necessarily technology that's widely available. And to you as ENT surgeons, we wanted to concentrate more on the clinical tests and what we call the bedside vestibular tests. And Sanjeev has covered quite a lot of these. I'm just going to show you some videos of what to look for when you're doing these tests. If there are any problems at all with seeing the videos, please let me know. We're going to start with the head impulse test, which I would say is one of the most useful, possibly the most useful way to look for vestibular pathology. It's testing the vestibulo-ocular reflex, which, as you can see here, Kanye is demonstrating that when he turns his head one way, his eyes go the other way. And they are constantly stabilized by the inputs from the ears by a 3-neuron arc, which allows the eyes to compensate for head rotation in all 3 dimensions. I'm sure you know all about this. It's really a 3-neuron arc, so it's straight out of the labyrinth, down the brainstem, and back out to the eyes. So it's the fastest reflex in the human body. And the way that we test it, let's take the top row to begin with. This is a normal subject. This is a normal person. We hold their head like this. We ask them to look at the end of our nose, and we turn their head quickly to one side, to the side that we are testing. As you can see, this subject's eyes are staying looking directly at the camera, and even after the end of rotation, he's still looking at us. He has no problem with his horizontal canals, so his eyes have moved perfectly well to the left as we've pushed his head to the right. Now, a subject with a right-sided vestibular loss, we push his head to the right, and his eyes drift with the head, and they're looking over to the right because they have not received the signal from the right labyrinth that would make them turn to the left. Therefore, afterwards, they have to quickly saccade back so that they're looking at our nose, at the examiner's nose. So after the head has been moved, the eyes quickly make a jump. This is called a catch-up saccade. And sometimes this is very obvious, and sometimes this is very hard to see. So the only way to get good at doing this is to do it a lot. So here is a normal head impulse test. As this subject is moved from side to side, her eyes stare completely at the examiner, and there are no catch-up saccades that we can see. Her eyes move quickly as the head moves quickly. This is a normal head impulse test, or head thrust test, sometimes called. Now, this is a right-sided test that is positive. So as this person's head is pushed to the right, you can see the catch-up saccade after the head is moved. And here it is in slow motion, so you can see it. He's going to push again. Push, saccade. I hope that's coming through clearly on the video. Yeah, good. So that's a positive right-sided head impulse test, and we want to really see that as a repeatable phenomenon. You want to see it at least 3 times in a row, that they do the same thing every time, that there is a saccade repeatedly to that side. Here is a positive left. So first of all, he goes to the right, and that's fine. And then when he goes to the left, there is the saccade. So this is a bit more delayed. So he goes right, no problem. And then he goes left and saccade. So I hope you can see that there. Here's another one to the left. Here we go, left, and that's very subtle. That's harder to see. It's very quick. And some people will find it hard to keep their eyes still when you're doing this. So it can be confusing because they're moving their eyes anyway, especially older people, which is why you need to do it repeatedly and check that it's the same finding every time. And then some people will have this bilaterally. People with bilateral vestibular hyperfunction may have large saccades either way. In this case, this person has bigger saccades over when the head is pushed to the left, but this is a bilaterally positive head impulse test. And you can see here in slow motion. So that's what to look for, a repeatable saccade after the head impulse. Now, when we're looking at nystagmus, if it's vestibular nystagmus, it is likely to be suppressed with fixation, which means that in the room, with the naked eye, in the light, any nystagmus which is caused by a asymmetry between the 2 vestibular systems may not be there so much. It's harder to see. You have to use Frenzel goggles or possibly video goggles to see this. If you're catching somebody very early on when they're having an acute vestibular neuritis, you may very well see this with the naked eye. But vestibular nystagmus is usually suppressed fairly quickly, and you'll need some kind of goggles to see it. The thing to know about vestibular nystagmus is that it always beats in the same direction. So it tends to beat towards the healthy ear because of the lack of VOR tonic function from the nerve on the impaired side, which means that the eye is pushed towards the impaired side and beats back towards the healthy side. So whichever direction of gaze this person looks in, it's always beating to the right. And when they look to the right, it's a bigger nystagmus. The beats are the speed of the nystagmus is quicker. Whereas with central nystagmus, this is what we call a gaze evoked or a direction changing nystagmus. So when he looks to the left, it beats to the left. And when he looks over to the right, it beats to the right. And you may see this in acute cerebellar or brainstem strokes that may look like neuritis in other ways, but they declare themselves with this direction changing nystagmus. Looking at the postural stability, a very well used and well-known test is the Unterberger stepping test, and you can see the patient doing it here, and we're looking for them to rotate for 245 degrees. I should say that the literature that has looked at this has found that this is quite a fairly low sensitivity and specificity for detecting vestibular disorders, and we do run into problems with older people because as we see the groups, the age stratified groups here, these are normal subjects with no vestibular disorders, and what we can see is that as you get into your 70s, you're naturally inclined to turn anyway, and that's very close to what we would classify as being a significant turn. So this can be useful, but it should be interpreted possibly with some caution. The Romberg test, which Sanjeev has covered, is just really a test of eyes open and eyes closed, and looking for any deviations in center of gravity. And the tandem or sharpened Romberg involves narrowing the base of support so that we have less information coming to the cerebellum from the distal proprioception. So it's much harder to do, And typically with eyes closed, this can be very, very difficult for somebody with a vestibular disorder. But the problem is here, of course, that it's quite difficult for lots of people, especially older people, to do for various other musculoskeletal reasons and various other neurological reasons. The test that we tend to favor in vestibular audiology is what we call the modified clinical test of standing interaction in balance, which we call the CATSIB, and it's 4 conditions. And we have, and this is essentially the Romberg, and then these two here are similar to the Romberg, but we stand the patient on some kind of foam, which limits the signals from the distal proprioception. So we have an eyes open and an eyes closed situation for either one. And the reason that we do this is we are trying to filter out the 3 primary sensory systems: the vision, the vestibular, and the somatosensory or the proprioceptive sense that's largely in case of standing balance coming from below and up through the trunk and the spine. So when they have their eyes open on a firm surface, they have all 3 sensory systems working. When their eyes are closed on a firm surface, we're removing vision, but they still have their vestibular and somatosensory senses. When we put them on a foam surface with their eyes open, they have to rely on their vision and their vestibular sense. But with their eyes closed on a foam surface, there really is only the signals from the ears left. So that helps us to filter down. And when people fail this reliably and cannot do this, it really does point you towards there being a vestibular disorder. This is fairly reliable. Some of the literature suggests that this gets less reliable over the age of 65 or so, but we do use it here over that age, and I find it to be quite reliable. It usually matches up with vestibular testing. And then very quickly, central vestibular system. As Sanjeev mentioned, if you're going to look at quick clinical tests here, we might look at saccades and smooth pursuit, and they might suggest the involvement of the cerebellum or brainstem. I won't run through this because Sanjeev's already showed you this, but here is a person with overshoot saccades when they look to the right and undershoot when they look to the left. So this person had a lateral medullary stroke, brainstem stroke, and if you look carefully here, you can see them making the saccade and then jumping again. So when they go to the left, that's the right sided. So when they go to the left, you'll see the undershoot. It's a saccade and a second saccade to complete it. There. Quite hard to see. This is a rare finding. You may not see this very often, but it's worth having in your test battery. Here's a person with an overshoot of the left eye. This person has internuclear ophthalmoplegia, and when they look to the left, you can see their left eye overshoot and come back on. You can also see that slightly when they go to the right as well. This is affecting only the left side. This is a unilateral INO. And then this is slow saccades. So this person is being asked to look quickly to the left and right, but they have very slow saccades. And this is also another central problem. Finally, smooth pursuit. Sanjeev has shown you how to do this, but what you're looking for is a saccadic, choppy pursuit. So they're making their pursuit with saccade after saccade after saccade. This person also has gaze-evoked nystagmus. So when she gets all the way over to the right, she will see that direction changing nystagmus we talked about earlier, because she has a fairly rare syndrome called canvas, which affects the cerebellum, the peripheral nerves, and gives you bilateral vestibular hyperfunction. And then this person has a fine smooth pursuit over to the right, and then when they pursue over to the left, you can see it's saccadic. So that's abnormal, whereas this is normal. So again, this person had a cerebellar stroke. Okay, and many of the videos here have come from this chap who was my mentor when I was in America. There's a really good library of free videos to look at all sorts of eye movements. So we can maybe put that in the chat so you can see that. But please do check that out. They're all free and they're very, there's lots of lectures on there as well. They're very, very useful. So I'm just going to finish by talking about BPPV. So now then, am I showing the right screen? That's the question.
Can't see it yet.
Hang on.
Got about 3 minutes, David.
Okay, I will be very quick. Are we seeing the BPV slides?
Yeah.
Okay, great. So we'll skip through this. Triggers you want to look for BPPV. There are 6 movements that will trigger posterior canal BPPV, which is the most common, by far the most common type of BPPV. There are 3 pairs: lying down or sitting up in bed, rolling over in bed to the left or to the right, and then finally looking up or bending down. That's the important thing. Those 3 pairs of movements are BPPV triggers for your classic BPPV. Quick horizontal head movements will tend not to trigger BPPV. Let's go to a whole pike. So here's Fiona Barker again. So she is moving the patient quickly down to extend their neck as quick as they can, and their head remains turned to the side that she is testing. And an alternative is a side lying test for people who cannot rotate who cannot extend their neck. They still need to rotate, and they can lie quickly on their shoulder. This is very useful for older people, but it is less sensitive than the whole pike because there is no neck extension here. And then your typical BPPV nystagmus will be torsional to the side that you have tested for posterior canal BPPV, and will last 5 to 30 seconds and start after a few seconds. Here's some more examples. This is a torsional nystagmus over to the right hand side. So that looks like right posterior canal BPPV to me. This one's harder to see because you can't really see the top of the eyeball. But if you look at this, these cluster of veins there, they're moving down, which means that the top of the eyeball must be moving in that direction. So again, over to the right. And here you have, this is over to the left. This is a left posterior canal, that's torsional. If you look at the iris or you look at a vein in the sclera, you can often work out the direction from that. Epley maneuver is our most used test. So that's the first position, is just like the whole pike. The second position is a turn of the head. You leave them in their positions for 1 minute at a time. The third position, you want to roll them quickly over onto their shoulder. And I personally would move the head down to look at the floor to really try and roll them around that final arm of the canal. So, but it's a roll of the body over, and then you sit them up to hopefully send the otoconia back into the utricle. And then the Simon maneuver, which is the alternative maneuver for people who cannot perform the Epley, it starts like the side lying. You turn their head away from the side that you want to test and lie them on the shoulder of the ear that you are testing. So this person is having their left ear tested, and she goes into that position, she stays in that position, and then after 1 minute, she moves from there all the way over so that her forehead touches the couch on the other side. This is an alternative for posterior canal BPPV. So 1 minute in that position, and then finally up she sits. So she's just had her left treated there, so her head should still be turned to the right, because with side lying and Simon, you turn the head away from the ear that you want to test. There are other positional nystagmus, don't worry about that, you don't see them very often. If you want to look into it, there's lots of literature out there. So essentially BPPV is very, very common. It's a very much adds to older people's falls risk, and you should always try and treat it if you possibly can. That's me done.
Thank you very much, David. I want to ask my first question to you. You said you did bedside testing with technology that might not be used. What kind of bedside tests are you doing, and for what patients?
No, so what I meant is that we do a lot of vestibular testing, which does involve a lot of technology, which we wouldn't necessarily call bedside testing. So we bring them in for a separate appointment, usually in audiology, and we would the classic, probably widely spread, would be some kind of nystagmography. So this would be either video nystagmography, or in some cases electronystagmography. And this is monitoring the eye movements during the test of saccade, smooth pursuit, and looking for nystagmus in various positions of gaze. And the advantage of that over the clinical test is that you can remove fixation by popping a mask over the goggles, or there are various ways of doing that. And then from that you can see vestibular nystagmus. Another widely used test would be the caloric test, which Sanjeev touched on, which is stimulating one side at a time, which is not something we can do with any other test. And that's producing a response from the horizontal canal using a change in temperature in the inner ear. And then more recently, we use a lot of video head impulse testing. So this is just like the head impulse test that I showed you, except it's delivered from behind, and high definition goggles will track the eyes and look for saccades, and they can see saccades that our naked eyes cannot see. There are other tests as well, but those are probably the three most useful.
And which patients are you doing that for?
Yeah, so that's a good question. It depends on the referral route. Typically from ENT, if an ENT doctor has done some clinical bedside testing or taken a history and is not quite sure of the diagnosis and feels that the patient needs more time and more investigations, then we will see those patients that haven't been obvious to the ENT doctor. And then we also see plenty of patients from neurology, from older people clinics, so falls clinics, geriatricians, and also from audiology and from other ENT centers as well. So it depends really, but it gives us, we generally spend 90 minutes with the patient, take a very big long history, and then do lots of tests with them.
That's brilliant, thanks. Gan, in Mongolia and in your practice, I know you're not a audiological specialist, but are you using these kinds of video tests?
I think sure we do, but I'm not so familiar with this. But I have some questions from the audience who's really associated with the audiology and vestibular thing. And there's 4 questions arises from the audience. The first one is what is the crucial thing to aware that when imbalanced patients coming? I think it's from the trainees, I think. This question I think is for David. And also the second question is,
can we go one at a time? Gan, just repeat that question for David.
What is the crucial thing to aware that when imbalanced patients coming, when you're just your first see? And the second one is the contemporary treatment management of vestibulopathy. I think it's a contemporary trend of management of vestibulopathy, I think.
For David, what are your most common presentations? And then Sanjeev would discuss
vestibular, what was the question? Vestibular paroxysmia.
Yeah, we'll get to yours second. David, if you just tell us about most common presentations.
Most common presentation. In outpatients, which is not acute, so we don't see a lot of acute vertigo. So we don't see a lot of nystagmus with the naked eye. We will see people who are generally off balance and they don't really understand why. Or people who have what we call motion-provoked dizziness, so they move their head quickly and they feel dizzy. And the trick is to work out when that happens, how long it lasts for, and what does it feel like, and then look into their history. If they had a very strong period of vertigo, but things are getting better, they're still a little bit dizzy when they move quickly, that smells a bit like vestibular neuritis. If they have a strong vertigo when they move in those particular ways that we talked about for BPPV, we might suggest that. And then there are other rarer symptoms that, take a while to go into, but I suppose those are probably the most common. Oh, I should mention one thing as well. We see a lot of vestibular migraine. It's much more common than I think that we used to think. And these are people who can have a wide range of symptoms. They often have a personal history of migraine or a very strong family history of migraine. And then they're overwhelmingly, they're largely female, and they can have changes throughout their life, often linked to hormones, that suddenly then the migraine starts presenting itself in a new way, which might be episodic dizziness, which looks a bit like Meniere's, but there's no otological involvement and no hearing loss. Or they may have chronic symptoms, they may have positional symptoms, but it's very, very key in the history taking, as Sanjeev said, to talk about migraine history.
That's brilliant. Thanks, David. So, Sanjeev, the question for you is, are there any new treatments emerging for, I think it was, vertigo, or vestibulopathies mainly? Is that right, Gan? Vestibulopathies?
Yes, it's a contemporary trend management of vestibulopathy.
Yeah.
I mean, it's quite a broad term. The International Classification of Vestibular Disorders, the Baroness Society, they've broken down these vestibular conditions into specific different areas. The vestibulopathy, which is the acute peripheral vestibulopathy, is what we see is previously known as vestibular neuritis. There's no specific treatment as such. People have had labyrinthine suppressants initially to suppress their acute symptoms, and then advised rehabilitation for them to recover. The other conditions are vestibular paroxysmia, which is a episodic vertigo lasting for up to a minute. Usually you get multiple attacks per day, up to 30, 40 a day. It's supposed to be due to compression of the retroventral part of the vestibular nerve in the international meatus, where they have oligodendrocytes. And that's because of the pulsations of anterior cerebellar artery. It's a bit controversial because a lot of people do have MRI scans with anterior cerebellar artery compressing on the nerve, but they don't have any symptoms. But in certain patients, this is known to be the case. They respond quite well to sodium channel blockers like carbamazepine and oxycarbamazepine. So that's one of the diagnostic criteria. If they respond to carbamazepine, then it's likely to be vestibular paroxysmia. There are not specific tests which would confirm that. The other vestibulopathies basically depends on your history and what category they fall into, like chronic vestibulopathy, which is triple PD. They need counseling, SSRIs, and psychiatric assessments and stuff to give them some benefits to help with their quality of life. That's all I can think of. Any other comments? I think Emma is on the call if she wants to add to it.
I'm on the call. I don't particularly have anything to add.
Thanks for joining, Emma. I wanted to ask, how often do you use MRI, and what kind of symptoms push you towards requesting MRIs for your patients?
So the MRI is basically if you have in your assessment suggestive of a vertical type of nystagmus. Generally, you see more often in central causes. If there are any problems with the proprioception, problems with the skew deviation, problems with the gait, acute onset of acute vertigo, which are supported by a normal head impulse testing. That could be a posterior fossa circulation problem, patients with asymmetrical hearing loss or unilateral tinnitus. So those are the patients who generally would need MRI, especially for the MRI of posterior fossa circulation. If you're suspecting a brainstem infarct, you need to have a diffusion weighted imaging. And you've got to be aware that for the first 24 hours, 50% of the MRIs can be normal. That's why the head impulse testing is so relevant. So generally, these are things which will point you to look for a central cause and ask for an MRI.
Yeah, I completely agree. And I think, I don't know if Emma, you want to chip in here, but I think here we have somewhat of a luxury of having access to MRI quite readily, and we have fairly low threshold for referring patients for MRI. Would you say, Emma?
Absolutely, yeah, I think that's a really good point. And actually, we touched on this theme when we talked about tinnitus a few webinars ago, which is that in a high-income health system, we scan too many people. Really, we scan everyone that comes with tinnitus or dizziness, and the vast majority of them are normal scans. So yeah, I agree. I think we're scanning too many people, and we should really be relying a bit more on our clinical acumen and the things that don't cost money and that we can do in the clinic.
And do you have any more questions?
Yes, I do have two more. And there's also two questions. So one of them is, any proper steps to diagnose imbalanced patients, how to they handle them when you just first see? And the second question is, how is the caloric test is the appropriate identification to discriminate brain dead patients in the ICU? That's the two questions.
So what was the second one, sorry?
Is the caloric test is the appropriate identification to discriminate brain dead patient in the ICU? Because the
That's fine.
Yeah.
David, do you do any ITU testing?
No. So yeah, no, I have read about that. I from my understanding, that was something that was once done, but it's certainly not something that we're asked to do anymore. And I imagine there are other much more accurate ways of assessing brain death than caloric irrigation. Although theoretically, yes, that is something that that might contribute, but we don't do that.
That's something
I think it can be quite cumbersome, especially when the patients in ITU. You've got a lot of lines, monitors, getting the actual access to the ear in the position the patients are in. It sometimes is tedious. So there are much more accurate ways of assessment of brain activity.
Thanks, Sanjeev. But yeah, I seem to remember historically that is one of the techniques we used to use. So less so in the UK now, Gam. And your first question was?
The first question was, any proper steps to diagnose imbalanced patient when you just first see?
Any proper steps?
Proper steps.
Yes, the proper steps to diagnose them appropriately, yeah.
So it's basically, as you have to follow a systematic approach towards history taking, and then a systematic approach to examination. So history taking will tell you whether the problem is in the labyrinth, or problem is in the central system, or problem is in the cardiac problem, or it's a neurological demyelination condition. Then you examine the systems accordingly, as we touched through to the talk today. And then it'll tell you whether you need further investigations, whether it's vestibular or otherwise. And that'll probably help you to boil down to what you might be looking for. So there is no one fixed regimen, but it is a group of assessments, including history and examination, which probably will tell you what might be the problem. So just to give an example, if you have to do a patient suspected of Meniere's on your history, there are no actual definitive investigation for Meniere's, but there are lots of things you can do. Patients have reliable history. The criteria for Meniere's is a true vertigo lasting anywhere between 20 minutes to 12 hours associated with fluctuating hearing loss, and a documented evidence of 30 decibels of mid or low frequency hearing loss on 2 occasions. So that will give you what if it's Meniere's or not. Previously, we used to do ECOGs, electrocoagulography, and glycerol dehydration tests. that's not done anymore. You probably may end up doing an MRI scan because patients have one-sided sensory hearing loss to rule out some kind of retrocochlear lesion. But that's kind of the logical pathway you take if the sister suggests there is a problem, and that'll change with different patients.
Gan, how accessible is MRI in Mongolia? And have you, I know you're not necessarily your area of expertise, but have you identified any key differences in the UK and Mongolian approach to vertigo?
First of all, I haven't get some response from the audience related to that topic. But in my point of view, what I recognize from my experience, we don't do any, not too much MRI scanning of the head when the patient who is suffering from vertigo. But the patient who is also suffering from concomitant issues, something like, yeah, of course, like 10 years old hearing impairment, yeah, we do have it. But the distribution of MRI servicing in the folks in the Mongolia is so low. Like also the audiologist who can evaluate the results of the MRI scan related to the specific discipline is also so low in the 100K people. So in my opinion, in your comparing to your expectation in the Mongolian folks is so incomparable, I think.
Great. Well, thank you, Gan. Thank you to our speakers. We're coming to the end of our webinar. I will just share now my screen with the QR code for the online reflective form. So please complete the form. We think it augments your learning following this webinar, and also it has some key evaluation questions for us to continue to improve the series. Gan, do you want to repeat that in Mongolian?
Yeah, sure. Өнөөдрийн сургалтанд хамрагдж байгаа хүмүүс яг энэ QR кодыг нэг бол утсаараа шууд уншуулад эсвэл сургалт дуусны дараа би Facebook нийгэмлэгийн Facebook group дээр холбогдох линкийг тавингууд тэрний дагуу орох survey form-ыг бөглөөд тухайн сургалтанд хамрагдсан сертификат авахаас гадна хамгийн гол нь тухайн энэ удаагийн сургалт маань та бүхэнд ямар үр өгөөж өгсөн эсрэг талаарх feedback хийж болно.
And I'll also put the link in the group there. Thank you very much again, David, Sanjeev, and Emma, and all the Global Health Committee for our fourth webinar. We will see you not next week, but in 2 weeks' time on the 10th of August for our fifth webinar in the series, which is oropharyngeal dysphagia.
Thank you for your great presentation to David and Sanjeev, and also Emma. Thank you for your cooperation. It is a nice constructive information for, especially for who is training for the balance issues. Yeah, thank you.
Thanks, everyone.
No problem. It was a pleasure. Thank you.
No problem.
Bye.
Bye-bye.
Bye-bye.